Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 465 of our pharmacotherapy series, which majors in adult hematologic malignancies. The next case reads, PAW, a 55-year-old man, is approximately 40 days after induction therapy with 7+3. Initially, his counts recovered on day 25, and a bone marrow biopsy on day 28 revealed less than 5% blasts. Therefore, he was in remission. Thereafter, a recent CBC showed a significant drop in his platelet count from 150,000 cells per microliter on day 30 to 90,000 cells per microliter 10 days later. A subsequent bone marrow biopsy reveals 60% blasts, confirming the diagnosis of relapsed acute myeloid leukemia. So my first question to you reads, what are treatment options for PAW at this time? In younger patients, failure to achieve remission or disease relapse remains the major cause of treatment failure. This reflects both the failure of current salvage regimens and the absence of effective strategies to secure long-term disease-free survival in those patients who achieve a second hematologic remission. A wide range of salvage options have been studied, but with less than 50% of patients achieving a second remission and median survival figures ranging from 3 to 12 months, there remains considerable room for improvement. The treatment of relapse in a patient younger than 75 years of age with a good performance status generally comprises one of several salvage options, including clofarabine, intermediate-dose cytarabine to high-dose cytarabine, or combination regimens such as fludarabine, cytarabine, and fulgrastim, abbreviated as FLAG, or cladribine, cytarabine, and fulgrastim, abbreviated as CLAG, followed by allogeneic hematopoietic cell transplantation. The results of PAW's cytogenetic and molecular analysis show that his leukemia is FLT3 positive. So my next question to you reads, what would be the next step for PAW? Whereas some clinical factors have an impact on response to treatment, it is the cytogenetic and molecular heterogeneity of acute myeloid leukemia that is the major determinant of treatment success or failure. For PAW, the finding that his acute myeloid leukemia has a mutation in the FLT3 gene portends a poor likelihood of long-term survival without new therapies. The estimated 5-year survival is approximately 10% to 15% among patients with a FLT3 internal tandem duplication mutation. Therefore, It is an attractive molecular target for the development of new therapeutics. Although several molecules have been reported to have inhibitory activity against FLT3, only a few have clinical trials to assess their efficacy in acute myeloid leukemia patients: lestortanib, midostaurin, quizartinib, sorafenib, and sunitinib. To date, FLT3 inhibitors have shown only modest efficacy as monotherapy in patients with relapsed or refractory disease. However, in vitro studies suggest synergism between FLT3 inhibitors and conventional chemotherapy. As a result, clinical trials are being conducted to investigate the combination of FLT3 inhibitors in combination with conventional chemotherapy like daunorubicin and cytarabine, along with hypomethylating agents such as decitabine and azacitidine, with the hope of improving the outcomes of patients with FLT3 mutations in both the initial and relapse setting. Some trials have been shown that there may be an increased risk for toxicity and infectious complications with combination therapy, and further research will be necessary to find improved combinations that can maximize efficacy and minimize adverse effects of treatment. For PAW, the best option would be to enroll in an investigational trial that incorporates one of the available FLT3 inhibitors with chemotherapy. If a trial is not available, then high-dose cytarabine or a combination regimen containing clofarabine or fludarabine followed by an allogeneic hematopoietic cell transplantation would be his best option. The next case reads, STE, a 66-year-old white woman, recently had a routine CBC drawn during her annual checkup. Her CBC showed a WBC count of 152,000 cells per microliter, with 15% basophils, a hematocrit of 32%, and a platelet count of 300,000 cells per microliter. The only pertinent physical finding was splenomegaly. On further workup, a bone marrow aspirate revealed a hypercellular marrow with less than 10% blasts. Cytogenetic analysis confirmed a diagnosis of Philadelphia chromosome-positive chronic myeloid leukemia in chronic phase. STE was asymptomatic at diagnosis, even though her WBC count was very high. So my first question to you reads, what are the possible clinical consequences of this abnormally high value? STE's labs indicate hyperleukocytosis, which would be a white blood count, WBC, greater than 100,000 cells per microliter. A major consequence of hyperleukocytosis can be leukostasis, which may manifest as dizziness, dyspnea, priapism, headaches, tinnitus, and cerebrovascular accidents. Interestingly, STE is asymptomatic except for splenomegaly, which occurs in 50% to 60% of newly diagnosed chronic myeloid leukemia patients. The presence of Philadelphia chromosomes within STE's bone marrow established her diagnosis as chronic myeloid leukemia, and the percentage of blasts and basophils confirm her stage. Less than 10% of blasts in the bone marrow and less than 20% of basophils in the peripheral blood space place STE in chronic phase using the WHO criteria for chronic myeloid leukemia staging. The next question reads, what is the prognosis for STE and others with newly diagnosed chronic myeloid leukemia? STE has been diagnosed with chronic phase chronic myeloid leukemia, which may range in duration from a few months to many years. Because symptoms can be nonspecific and relatively minor, chronic myeloid leukemia may remain undiagnosed until patients progress into more advanced stages. STE's prognosis is good and her projected 10-year overall survival, abbreviated as OS, is 80% to 90% if treated with a tyrosine kinase inhibitor. If STE's leukocytosis progresses despite therapy, an increased number of immature leukocytes, that is blasts, would appear in the peripheral blood signaling the second phase of the disease, the accelerated phase. The accelerated phase can progress quickly to blast phase if left untreated. The estimated 4-year overall survival is 40% to 55% for those patients with accelerated phase chronic myeloid leukemia who are started on a tyrosine kinase inhibitor. The final phase of the disease, blast phase or blast crisis, is defined as 20% or more blasts in the peripheral blood or bone marrow by the WHO or 30% or more blasts in the blood or bone marrow by the European Leukemia Net. During this phase, chronic myeloid leukemia is indistinguishable from acute myeloid leukemia with the exception of cytogenetics and is often refractory to conventional induction chemotherapy regimens for acute myeloid leukemia when treated. The median survival for patients in this phase is approximately 9 to 12 months, with allogeneic hematopoietic cell transplantation considered a good first-line treatment option. The next question reads, what therapy is appropriate for STE's chronic phase disease? With the approval of the tyrosine kinase inhibitors, treatment of chronic myeloid leukemia has shifted towards disease management. Because SE was asymptomatic upon presentation, she will receive one of the tyrosine kinase inhibitors approved for first-line management of chronic phase chronic myeloid leukemia. We will now briefly look at tyrosine kinase inhibitors. Imatinib, a first-generation tyrosine kinase inhibitor, inhibits BCR-ABL kinase, which prevents phosphorylation of substrates that are involved in regulating the cell cycle. Approval was based on the pivotal international randomized study of interferon and STI 571, abbreviated as IRIS, trial, which compared imatinib with the combination of interferon alpha plus low-dose cytarabine in patients with newly diagnosed chronic myeloid leukemia in the chronic phase. A total of 1,106 patients were randomized to either imatinib, dosed at 400 mg orally daily, or interferon cytarabine. All primary and secondary endpoints of the trial demonstrated superiority of imatinib versus interferon cytarabine. Based on the results of this trial, tyrosine kinase inhibitors became standard of care as first-line therapy for patients with newly diagnosed chronic myeloid leukemia in chronic phase. At the 8-year follow-up of the IRIS trial, 55% of the patients were still taking imatinib, and the estimated overall survival was 85%. The most common toxicities reported with imatinib are superficial edema, nausea, muscle cramps, and rashes. Dasatinib is a second-generation tyrosine kinase inhibitor that binds the BCR-ABL protein in the active conformation, making it 325 times more potent than imatinib. Approval was based on the international DASISION, dasatinib versus imatinib study in treatment-naive chronic myeloid leukemia patients, trial, which compared dasatinib with imatinib in 519 patients with chronic phase chronic myeloid leukemia. The primary objective of CCYR at 12 months and the secondary objective of a major molecular response by 12 months was statistically superior for dasatinib versus imatinib. Dasatinib demonstrates a similar safety profile compared with imatinib, but with a higher incidence of pleural effusion, pulmonary hypertension, and thrombocytopenia, as well as a lower incidence of rash and diarrhea. Nilotinib is a second-generation tyrosine kinase inhibitor which is structurally similar to imatinib, but 30 times more potent as a result of an improved structural fit in the receptor pocket. Approval was based on the International ENESTND, an abbreviation for Evaluating Nilotinib Efficacy and Safety in Clinical Trials, Newly Diagnosed Patients trial, which randomly assigned 846 patients with chronic phase chronic myeloid leukemia to either imatinib or 2 strengths of nilotinib. At 12 months, both doses of nilotinib were statistically superior for molecular response and CCYR compared with imatinib. Upon follow-up, molecular remission rates between the nilotinib arms and the imatinib arm increased from 6% to 10% at 1 year to approximately 21% to 23% by 5 years. Nilotinib demonstrates a similar safety profile compared with the other tyrosine kinase inhibitors, with a higher incidence of rash, headache, pruritus, and alopecia, and a lower incidence of nausea, diarrhea, vomiting, edema, and muscle spasm. Clinicians and patients must carefully evaluate the potential risks and benefits of each treatment modality to make the best therapeutic decision for each individual situation. Because STE presented in chronic phase chronic myeloid leukemia, initiation of either imatinib, nilotinib, or dasatinib is an appropriate choice, but STE's physician chose to start her on imatinib 400 mg once daily. On routine follow-up at 3 months, STE is found to have an 11% BCR-ABL transcript level. Her side effects and compliance were evaluated, where she was found to be 90% compliant due to nausea. She was counseled on medication adherence as well as what she can take for nausea, and then re-evaluated at 6 months. The BCR-ABL level was measured at 15%, and her bone marrow revealed 36% Philadelphia chromosome-positive metaphases. Because STE's compliance had improved, the disease appeared to be resistant to imatinib. Imatinib was discontinued and dasatinib was initiated at 100 mg once a day. STE maintained low BCR-ABL assay levels until 12 months, when her level was measured at 12%. Cytogenetic analysis revealed that STE had become resistant to dasatinib. So my next question to you reads: what treatment options are available for STE at this time? Primary cytogenetic resistance is defined as failure of the patient to achieve any level of cytogenetic response at 6 months, major cytogenetic response at 12 months, or CCYR at 18 months. Just like 15% to 25% of all patients who start on imatinib therapy, STE appeared to have primary cytogenetic resistance at 6 months, which prompted therapy discontinuation. Medication adherence can affect resistance rates as well as outcomes. In the Adagio study, 1/3 of patients were noted to be non-adherent to imatinib therapy, with suboptimal response occurring in those with higher rates of non-adherence. In STE's case, adherence improved, but nausea was problematic, so a dose escalation of imatinib from 400 mg daily to 400 mg twice daily did not seem prudent, given her symptoms and cytogenetics. Although STE has relapsed, she has multiple options for treatment: dasatinib, nilotinib, bosutinib, ponatinib, and omacetuximab. Both nilotinib and bosutinib can be used for second-line treatment, while ponatinib and O-mace-taxine are generally reserved for patients with resistance or intolerance to at least 2 tyrosine kinase inhibitor therapies. Bosutinib is a tyrosine kinase inhibitor that has shown effectiveness in patients with resistant chronic myeloid leukemia. Of the 118 patients pretreated with imatinib, dasatinib, and/or nilotinib, 24% achieved CCyR with bosutinib, thus estimating the 2-year overall survival to be 83%. Ponatinib is a tyrosine kinase inhibitor which can be used in patients who have exhausted other tyrosine kinase inhibitor options or in patients with a particular gene mutation, T315I. In the PACE study, which evaluated heavily pretreated patients, major cytogenetic response was achieved and maintained for 2 years in 89% of patients, and overall survival was 86% at 2 years. O-mace-taxine is a protein synthesis inhibitor which can be used in patients who have failed at least 2 tyrosine kinase inhibitors. An average cytogenetic response of 20.5% was found in one study of tyrosine kinase inhibitor-resistant patients who were given O-mace-taxine. STE's next treatment would likely be based on her tolerability of the first 2 therapies, her genetic mutations, her concomitant medications, and her comorbidities. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 466.